Welcome back to Health Talk. Today's specialist is Dr. Sam Kazziha. Sam, thanks for joining me in this conversation. And let's talk a little bit more about the FDA guidelines that have just been changed. Who is eligible for this procedure now?
So as stated earlier, that initially the procedure was approved for people who are considered to be high risk, patients who could not really have surgery. Of interest, a recent study looked at large number of patients who were really could have had surgery and they were considered to be low risk, yet they were really divided to two groups. One got the TAVR, got the valve without surgery, and the other one got the surgery. Of interest, the patients who had the TAVR did as well as the patient who did surgery, and in some cases they even have better outcome because it's lower risk and lower potential complications. So based on this fact that it is not inferior to having surgery, the FDA has approved it for people who can choose now, if they have this procedure, to say, if they have aortic valve stenosis, say, well, I don't want to have surgery, I'd like to have really without surgery. One thing I want to really bring to your attention, that the valve being replaced, we have had experience with it for about 7 years now. So we don't know for sure the long term of those valves. So let's say a patient goes through surgery and have what we call bioprosthetic valve. Bioprosthetic valve, that means it's not mechanical. Those valves' lifespan is usually about 10 to 15 years. The ones we are doing through a catheter is similar to the type is being used in surgery. So far, we know that they have done very well for the last 7 years. We don't know how they're going to do in 10 or 15 years, but we expect it to really last and do as well, but yet time will determine. That's fact number one. So there will be a tendency that doing this valve will be reserved more for patients who are a little bit older. I would be probably hesitant to do it for somebody who is early 60 because at the age of 70 they might need to have a valve. The other thing is, one of the interest is a patient could have had a valve done surgically and the valve now deteriorated after 10, 15 years, and now they are older. Now we can put a valve within a valve, but we do it this time without surgery and we do it through a catheter. So now we have much more options for our patients, and we can modulate the therapy to fit the patient's characters and their comorbidities. So that's major changes for the ability for us to take care of our patients rather than tell them you're out of luck.
Absolutely. So if someone has had valve replacement earlier, they could have a second valve with the TAVR procedure?
That's true.
But you would like the TAVR implant to last throughout their life?
It would be nice, but so far we don't know that for sure. We know even if you do it surgically, it doesn't last forever. It lasts 10 to 15 years, and you might need to have another valve. And so if you have had surgery, we can replace that valve not by undergoing a second surgery, but by putting another valve within a valve and take another 10 to 15 years, hopefully.
That's exciting.
So time would tell. The technology is always evolving and changing, and I'm very hopeful that we'll be able to achieve the same goals as far as longevity with those valves as we do with surgery.
Okay. So Henry Ford Health Systems has performed more than 1,500 of these, and I understand that Dr. O'Neill from Henry Ford Health Systems was the first to perform TAVR in our country.
So, Dr. O'Neill has been a maverick. He has been always ahead of the curve in many ways. In fact, he's my mentor. I trained under him 30 years ago, and he had always been the pioneer, for instance, in primary angioplasty. For instance, people have had heart attack. Under his supervision 30 years ago, we were the first in the country to be performing regularly angioplasty for patients who are having a heart attack, when in fact that was not the standard of care, and now it becomes the standard of care. So the same thing he did, like in any other projects, he was the first to really implant a valve percutaneously in 2005, and from that time on he became the person who really kind of was one of the physicians around the country who led that project of really enhancing this technique, improving about how we do it, and we are so happy that he's at Henry Ford. He had really rebuilt the structural heart program, And with his name and his capabilities, Henry Ford became the mecca for really structural heart disease management, including valve replacement, not only for the aortic valve, but also for mitral valve and other very highly technically demanding procedures. Henry Ford Macomb, being part of the Henry Ford system, had been able to capitalize on his expertise and have him come over to Henry Ford Macomb, not only to perform the procedures, but also to assist and help the interventional cardiologists in gaining the expertise and the knowledge to perform those procedures in a safe manner. So as I said, it's a teamwork, and he is leading that. I am one of those physicians who are performing the procedure with him, but I'm also, as an administrator, making sure that the whole team work efficiently with each other, including cardiologists, surgeons, technologists, nurses. And you can see the beauty of this procedure for a change compared to a lot of other procedures. It really requires collaborative work. Without collaborative work, this procedure would not be successful.
Yeah. Well, it sounds exciting, and I'm curious to know what made you decide to go into heart surgery? You could have been a doctor of all different types of medicine.
So to start with, I never really wanted to be a doctor. Let's start with that
Okay.
statement. I always say that. I was very good in math and physics. I always thought that I should be an engineer and should be maybe in business. And my dad kept telling me, "You're crazy, you should be a physician. This is a great profession." And so after discussing this, I decided to give it a shot. So when I went to med school, I can tell you the first 2 years I didn't like it. It was a lot of memorization. It's a lot of hard work, obviously. But then it clicked when I started seeing patients and become a problem solver. Suddenly, it really became a love affair for me. I enjoy doing it because now I can see. I'm a people person. I'm not just books. Having said that, as I studied medicine, cardiology was very easy for me to understand, was simple for me compared to other areas of medicine. So I can tell you, frankly, I'm glad I did cardiology because it fits my personality, and I enjoy doing it more than any other parts of medicine.
Well, that's great. Thanks for sharing that with us. Now, I'm curious to know, when you're in the operating room, how different is it today doing the TAVR procedure than the old way of doing the opening of the chest?
So cardiovascular disease management takes two types of physicians. One historically has been always the surgeon. So even if you have blocked arteries in the hearts, in the old days you would have bypass surgery. Still, bypass surgery is one of the most important procedures done for those patients. Again, that included to be in a large operating room, general anesthesia, cracking the chest, being in the intensive care unit. Versus balloon angioplasty and stent for the arteries of the heart came later on, and it did not replace, but it complemented. So I want to always say that the surgery part and the endovascular, which we do without surgery, complement each other and tailor the therapy for our best outcome for our patients. There is no question that patients who will undergo through a procedure through a catheter, it's much lower risk from the point that they're not being exposed again to the general anesthesia, and they're not being exposed to a major cut in the chest, opening chest. So there are cases where angioplasty, stent, or procedure like this would be the optimal, and there are cases surgery would be the optimal thing for our patients. But the way it got changed now, that our patients' ability to go home within 24 hours, ability to sit up and walk and eat as if like nothing happened, ability to be able to converse with us while we're doing the procedure. I mean, what a difference compared to being in the hospital for a few days after major surgery and potential complications. Now, both procedures can have complications, but definitely, again, surgery has a higher potential just because of the complexity. It requires a skilled surgeon, just like it requires a skilled interventionist. But a lot of our cases, it requires both physicians to decide and discuss what would be the best for the patient. And the cardiologist has been really sort of the person who really evaluate the case. And there are times we ask the surgeons to look at the case and give us their opinion. One of them is like in the TAVR, and there are cases we feel that direct intervention without surgery is the right thing for the patient.
We're in good hands. What made Henry Ford Health Systems decide to expand to Macomb?
Population is increasing in age. The distribution of aortic valve stenosis or valvular heart disease is becoming quite prevalent, so more and more patients having this issue. The guidelines regarding doing this procedure from reserved for very high risk to really low risk means there will be more demand for that. So Henry Ford also, as a system, realizes that it's not all about being in downtown. It has to go to the suburbs and it has to serve the community. So it's going to serve state of Michigan, but also it's going to serve the neighborhood. And by expanding this technology to local areas, our patients are able now to receive the same therapy they would have received downtown in a hospital near their home, near their family, and having the same expertise coming in. So now it's really spreading the love, basically. In the beginning, you have to start in one place, perfect it. Once you perfect it, then you can really export it to other places, and that's exactly what's happening.
Yeah, well, we're so grateful for your 3 offices, and our community can come in and get their top-level heart care right from you, right in our own area.
Well, thank you very much. We love the community. I had the practice started here more than 15 years ago. We've known that this community is a growing community in need of quality care, and rest assured that Henry Ford, not only through cardiology, but through different specialties and primary care, they are available in the area to serve the community and help them to direct them to the proper place where they can receive their care.
Well, thank you for that. What other sorts of advanced procedures are offered at Henry Ford Macomb?
So Henry Ford Macomb provides a large spectrum of procedures and preventive care. When it comes to procedures, we do vascular intervention, meaning people have blocked arteries of the legs. We can do that without having surgery. So again, everything is shifting to what can I do for my patient short of having undergoing surgery, and surgery should be the last resort. So people who have what we call claudication, blocked arteries in the legs, they have tightness in the legs, they are diabetics and they have issues, we can look into that, and we're now doing more and more procedures, also in combination with vascular surgeons sometimes, what we call it like in a hybrid room where they do part surgery and part without surgery. Another procedure which has been expanding significantly at Henry Ford Macomb is what we call atrial fibrillation ablation. A large number of patients now have irregular heartbeat called atrial fibrillation. Atrial fibrillation is a disease which will increase your risk of having a stroke. You have to be on blood thinners, and I think you really should have a session just for atrial fibrillation at one point in the future. But we have now the technology where electrophysiologists, who are cardiologists like me, but they're electricians as opposed to plumbers, and they're working on the electrical wiring of the heart, and they try to abort the patient of having atrial fibrillation. It improves the heart function, it improves the quality of life. Doesn't mean that they shouldn't stay on blood thinners, so that's also increasing. We are able to still do devices where it protects the heart from sudden death. It's called the defibrillator, and that has been happening at Henry Ford Macomb for quite a while. We are able to also bring a device called Watchman. This will be started very soon for patients who cannot be on blood thinners, and we can put those devices to protect the patient from having a clot dislodge from the heart and go and cause a stroke. People who have holes in the heart, called PFO for instance, now we can close it without surgery also. This has been going on. We have done already about 2 or 3 cases just over the last month. So you can see many things are happening in the cath lab. It's advancement in a lot of procedures we can perform for our patients. But really, Henry Ford is not just about procedures. Henry Ford is about patient's care and preventing you from requiring those procedures. We want to concentrate on our patients and our community, that we don't want them to have procedures. But if they needed some, we're going to be there ready for them and with the best care they can receive.
Well, thank you so much for sharing that with us, and thank you so much for sharing your information. We'd love to have you back on some more of those exciting topics. But before we go, the holidays are upon us. How can our viewers stay heart healthy at home?
Well, so holidays, I mean, there is nothing more lovely than the holidays where you have the family around and everybody sharing a meal. Just don't overeat. Don't eat late. A lot of us, unfortunately, tend to eat late in the evening. It's the worst thing you can do is eat and go to bed. So if you can have supper but earlier rather than late, rather than dinner, like anything after 7 p.m., I think it will become really pushing it, especially if you go to bed by 11. The portions of the food we eat, we should really try to minimize. I'm not telling people not to eat meat, but they should really have varieties. So recommendations: have a bowl of fruit next to your bed, or vegetables, so when you're hungry you can munch on this rather than having crackers or other things which we nibble on and which cause us to gain weight. And a third of fruit, a third of vegetable, and some meat, and nothing marbled, nothing with fat would be good. Avoid chicken with skin, have the white meat. That would be good. People tend to eat a lot while drinking alcohol, so that's something they need to be aware of. So the problem is this should start when we are young, to teach our kids to do that. So when we are older, it becomes a habit. The habit is very hard to break. What works for me is having something to weigh yourself every morning. So if you weigh yourself every morning, you'll become more conscientious about what you should eat. So keep that in mind. These are simple things you can do, and the most important thing, which I haven't been doing as well, but I'm trying, is walking. So if you can walk on a daily basis for about 30 minutes, you will live longer and healthier.
Thank you for sharing that information with us today, and we look forward to having you back on Health Talk. And thank you to our audience for watching Health Talk on WBRW TV.